of the soft tissues and put an X-fix on, and then we can do a tomography and see what happens to the joint surface. And you see it is a C3 fracture. It's several fracture lines, displaced fracture lines, but still a relatively simple one. So we waited for the soft tissues to settle, and then through the surgical fractures we entered that depressed joint fragment, brought it down, fixed it with a resorbable pin, and then the joint door was closed again, and it was stabilized with a plate that was slid in subcutaneously in a so-called MIPO technique, minimally invasive plate osteosynthesis, so that we did not need to open the former wound again. These are the soft tissues after surgery. You see the screws on the top were introduced via stab incisions, and there was an additional lateral approach for the anterolateral plafond. This is the patient more than 1 year later with an almost normal range of motion. Of course, still he doesn't dare to run, but it should be possible. This is the typical case that we see, C3 fractures or multiple lines, both in the ankle joint and in the metaphysis. Doesn't look so bad overall on the X-rays. But on the CT scan, you can see the multiple fragmentation of the joint surface. So again, the treatment is, in most of the time, is early external fixation and then scanning. There are some works out that also an early total care, early complete osteosynthesis of the tibial pilon is feasible if you have the correct equipment, if you have an OR ready for several hours, and if you have enough experience with that. Then your results are probably not worse than with a staged procedure. In practical terms and in daily life, this in our hands is much more feasible. One question is, do you need to fix the fibula? Those guys here did it and then transferred it to our hospital. We are not happy if anyone who does not do the final fixation of the pilon fixes the fibula first, because there's one approach that might affect your planning, and if the fibular fracture is not fixed perfectly, then it might even impede the fixation of the tibial pilon. And I personally like to have the pilon as mobile as possible for reconstruction of the joint surface. This concept was first actually published in French by Mathieu Assal from Geneva, of the 3 columns of the lower end of the tibia, just equivalent to what we heard in the last session about the upper end of the tibia. But it is based on the main fracture lines that we can see, but as you can also see, there is of course a corridor of the most common fractures, but there is much more to it, and the fractures are very individual. And there's the big question, if you need to fix the fibula, that means the lateral column at all, or if you don't need to do that. So I like much more, it's not a classification, but it's a method of assessment by Urs Heim. He defined the 6 fragments that you will almost always encounter in those complex fractures. And particularly those central, those die punch fragments, which are here the number 6, those fragments are not in the column description, and they are also not in the EO classifications. So after the CT scan, seeing and identifying the fragments is very important. And then the approaches. In some older textbooks, you still find approaches that are curved posteriorly. This is very dangerous to the blood supply. We know the blood supply to the skin is very important. As we know, also from French surgeons, the blood supply is abundant around the lower leg. So our task when going there is doing longitudinal incisions and not to disturb the blood supply anymore. So also for medial and lateral, the approaches should be curved anteriorly. And there is no standard approach for me to a pilon fracture. There is an individual planning. So this is the patient that we already saw. What to do? If you go with an anterolateral approach, which is frequently used in pilon fractures, we end up in the middle of that big chapu fragment. And we have to do a lot of dissection along the periosteum to enter the fracture. If you do a classical medial approach, same thing. We end up over the medial iris, which is typically one large fragment in pilon fractures, and we have a long way to the fracture, to fold it away. So for me, the best thing is to do a central approach directly on top over the fracture, which avoids soft tissue dissection and also avoids periosteal dissection. And then, of course, we have to plan it. This is a drawing from Patrick Cormier from France. I can't do it that nicely. Our residents love the computerized thing. I do it the old style, just with a paper and pen. But it's important to know to put the jigsaw puzzle back together and make some planning. And then, when we do the approach, we can see that. You can see the periosteum is still attached on that fragment, and door is opened, and the periosteum is left intact. And this is my best friend for those articular fractures, just a femoral distractor. So I leave one pin in the tibia and one pin in the calcaneus from the initial transfixation, and then I can distract. I can see and identify those thigh punch fragments, those central fragments, and then I can put them back together. Please also see the damage that the pilon fracture does to the talus, to the surface of the talus. So these patients, of course, have a high risk of arthrosis. The best we can do as surgeons is to put it back together as good as possible. So we reconstruct the die punch fragments, and more often than not, I put the K-wire all the way through the back, make it flush with the intercalated fragment, and then when the door is closed again, then the wire comes back. And if I am happy with the wires and there are small fragments, I just leave them in, I cut them flush as so-called lost K-wires. And then in complex fractures, I like to turn the type C into a type A. So I reconstruct the whole joint surface as long as it is still mobile and I can still distract it. And then when the joint block is one piece, I fix it to the metaphysis. In more simple fractures, it is also feasible first to turn it into a B fracture, mostly the medial side, and then you can build up your joint to that constant fragment. So here we have the final osteosynthesis with a locking plate and some additional screws coming in from the medial side. Depending on the size of the fragments and the quality of the bone, you can also opt for a medial plate, which is then brought in a midpole technique. So this is the patient, and you see if you're nice to the soft tissues, they will recover 10 days later, and this is him 8 years later, and he has a nice plantar flexion. He complains about missing dorsiflexion, and as you can see here, there are some osteophytes in the front. If you follow the patients long enough, everybody will have arthritis. The question is it painful arthritis? Because then we discuss fusion or arthroplasty. The best thing is the whole ankle of the patients. So we just did an arthrolysis, and he went on with his own ankle. Here's a second example, similar fracture where we decided to do a dual plate. So we went to an anterolateral approach for the anterolateral plate, and then with the midpole technique, the medial plate. And we are rather generous doing a post-op CT scan. We discussed in last session intraoperative versus post-operative CT scans. Most of the time our spine surgeons and the pelvic surgeons have the 3D scan, so we do it afterwards. So the prognostic factors that we can influence as surgeons is the perfect reduction, which of course requires some experience. How about palliative fractures? They are quite distinct. They are more not central impaction, but it's a combination of a position, a supination or pronation position of the foot and some dislocation mechanism. That means the ligaments around the ankle are as important as the bony structures. And as you can see, the anterior and posterior syndesmosis are very important. They hang on to bony fragments, and according to Lage Hansen from Denmark, a very smart surgeon who tried to produce all those fractures by himself, a ligament injury to medial or lateral side is equivalent to a bony avulsion there. And if we consider the external rotation mechanism, we can see that all four corners of the ankle, all four pillars of the ankle can be injured, either with ligament or with bony injury. So, in fact, we don't call them all malleoli. Long time ago, the posterior part, the posterior tibia fragment has been called the third malleolus, and I think if you do that, it's also logical to call the anterior part the anterior malleolus, because all these fragments have to be treated. Why is it so important? With the posterior malleolus, we had those rule of thumb that about 1/4 or 1/3 of the joint surface have to be fixed. Now we know there's more to it, so here it has been fixed in an indirect manner. Doesn't look so bad on the X-ray, but the medial clear space looks a bit wide. And here you can see the posterior malleolus is, with that indirect approach, is not reduced at all. The incisura is not there, so the fibula doesn't know where to go. So we went back from behind, and now with the fibula in place, there is a good alignment also of the fibula, and then the alignment of the ankle and the medial clear space closes down. So with the CT scanning for posteromedial fractures, we are very generous with them. We can see the morphology, and if it's just an avulsion of the posterior rim, that doesn't affect the incisura, the types 1. We can treat them non-operatively. But as soon as it's entering the joint and entering the incisura, if it's displaced, it should be fixed even if it's less than 25 or 30%, and there's a lot of evidence for that. And then, of course, it's better to come from behind to directly reduce and fix those fragments. That are those that go all over the way to the medial malleolus, but typically, in contrast to the Pilon fracture, it splits the medial malleolus, and then are the classical big fragments. So here's one example of a female patient with a fracture that extends all the way into the medial malleolus. The posterior colliculus is there, and also has an intercalary fragment that is impressed. So it is, if you want to, it's like a posterior Pilon variant. There is some momentum of axial impaction to those patients. So we go there from behind, and with this, via the same interval, we can fix both the tibia and the fibula. We start with the tibia because then we can still see the alignment of the ankle joint, and more often than not, after fixation of posterior syndesmotic avulsions, bone to bone, the syndesmotic complex is stable. And why care about the anterior fragments? Because it's the same thing. These are like the little brothers of the posterior fragments. If they are not in place, the incisura is not there, so the fibula doesn't know where to go. And it also affects the syndesmosis, because the syndesmosis is hanging onto it. So any displacement of the fibula takes that fragment with it, and the ankle mortise is unstable, and the syndesmosis is unstable. So we have to go back and fix them directly with screws. So when we looked at those fragments, of course the great majority are avulsion fragments, and you can leave them alone, but if displaced, we have a low threshold, just fixing them back with the suture anchors. Same thing with the type 2. These are articular fragments, so if they are displaced, the joint is not working, and the joint surface and the incisura is not there, so fix them just with a screw or with a washer. And the type 3 with a platform impaction, which you can consider like an anterior Pilon variant, they of course all have to be reduced and fixed. So this is one example for the most complex type you can think of. All 4 malleoli are fractured, and so in my hands, it is the patient is prone. You start with the posterior malleolus, then you add the fibula, either with the same approach or here with a higher fibular fracture, we add the lateral approach, and then the medial malleolus, and finally the anterior fragments are fixed. And we are very generous with the post-op CT scan to check if the reduction is fine. You see here, this was a very tiny intercalated fragment that we rather took out. It's better to take out those tiny fragments if they are not feasible for fixation than to have a free body in the joint moving around. You can see the reconstruction of the incisura, and you have bone-to-bone fixation of the anterior and the posterior syndesmosis, so there's no need for a syndesmotic screw or something else like a dynamic implant. So all those problems are avoided with direct fixation of those syndesmotic avulsions. So we have gotten more and more generous with a CT scan in ankle fractures because there's a lot of the times there's more to the picture than you just see with plain radiographs, particularly those syndesmotic avulsions, tiny intercalary fragments, and these are also indications to fix those fragments back because they contribute to syndesmotic stability, they contribute to the incisura, that means to fibula reduction, and to the joint congruity if fixed. Now, finally, to the calcaneal fractures, and of course, there's a lot of literature and a lot of controversy. Do we need to fix them or not? I'm not going into detail with those studies because some of them are rather complicated, but all of us who treat patients with foot and ankle pain, we will see those sequelae of malunited calcaneal fractures either after normative treatment or after operative treatment without anatomic reduction, which is probably the worst for them. But, of course, to avoid bad results, we also have to respect the contraindications, and again, it's about the soft tissues. So patients with diabetes that is not well controlled, or with neuropathy, this can be a catastrophe if you start operating calcaneus on them. Also those patients with drug abuse, if you see the bottle of alcohol next to the driver's seat, probably that patient has a problem with compliance, immunodeficiency, and then severe vascular disease, which is again against soft tissue complications. The classification by Sanders is the easiest one. It is prognostic and easy to apply, and I also like in analogy to the Ursheim planning. I like the planning that was put for my former chief, Hans Zwipp, identify the 5 main fragments that you will regularly encounter. So the main fragments are the tuberosity and the sustentacular fragment. Then you can have a variable amount of joint fragments, the posterior facet, and more often than not, the fracture expands into the anterior process and can split that into, so that you have an anteromedial and an anterolateral fragment. And then frequently, which is marked as a B, the thin lateral bone of the calcaneus bulges out, but this is not configured a fragment. Approaches are very important because we want to avoid soft tissue problems. So if you go for a big approach, you have to go really big. And you have to keep all the vessels, nerves, tendons in one flap that you raise from the lateral wall. It's a lot of dissection, you have to be very careful, and it takes some time until you finally see the subtalar joint. Going with a straight approach, right, to the subtalar joint, this will cut through everything that you want to preserve. The lateral calcaneal artery, the sural nerve, and the tendons, which will be right up in the way. So if you want to go for a small approach, you have to go over the top, over the sinus tarsi, and then you have a nice overview over the joint. And for me, I grew up with the extensile approach. I learned it that way. For me, this was a real game changer. And meanwhile, I think 80 to 90% of calcaneal fractures with that small approach. It allows you to see the joint reduction, and it allows you to the patient to have a stronger and fast rehabilitation. If you go with a big approach, you really have to wait quite some time until the soft tissues settle down. This is one example where we didn't dare a sinus tarsier approach, a complete blowout of the lateral wall, but also a displacement, a dislocation at the medial wall. So we used a large approach, and as you can see, it has to be large. Everything is kept in that flap. We start with alignment of the medial wall, so the main fragments, the tuberosity and the tentacular fragments are aligned to each other, because this makes the way for the joint reconstruction. If the tuberosity is not back down there, you have no chance of reconstructing the joint. You can do this on the direct vision, and the first screw is an independent screw that goes into the subtentacular. And then you can realign the posterior block onto the anterior process, and you can reduce and fix the anterior process via the same approach. In the end, you can put a plate on, and if you're not sure about your joint reconstruction in a really comminuted fracture, you can do just a short, dry arthroscopy to make sure you're correct, or you borrow the 3D scan from the spine and pelvic surgeons and can do a scan. This is the patient. She had bilateral fractures 1 year later, and she wanted to have the implant removed for better sagittal motion. Of course, for better lateral motion. The sagittal motion was perfect. And when we do this, we take out the plate and we add some arthrolysis and tenolysis, because frequently, even in perfectly reconstructed calcaneal fractures, you can see the arthroscopy after the arthrolysis, so the fracture line is barely visible. With doing this and doing a perfect reduction, then you have a chance for the joints to survive. And arthrolysis is needed for the dense scar that we encounter after larger approaches. So step by step we went into sinus tarsier approach, and even in Sanders type 3 and Sanders type 4 fractures, this is possible. The distraction is the same that we use in the open and in the large approach. It helps us a lot with bringing the tuberosity down. Still, we can lever, and this so-called tongue type fracture, where the articular surface is hanging on the lateral part of the tuberosity, this so-called Westfuss or Essex suppressive maneuver is very helpful with loosening up the fragments. And then, once the medial wall is reduced, we reduce step by step the joint from the medial side to the lateral side. In analogy to the Pilon fractures, we start with a K-rod that goes all the way out to the lateral side, and then step by step we bring it back. And we can control this very nicely. I personally see more of the subtalar joint when I look there from the top than working my way up from below. But if you're not sure, in this case with the Sanders type 4 fracture, again, you can control it with dry arthroscopy, which doesn't last a long time. And then a small plate is slid in, again, in a Whipple technique. And this is the patient's 3 months later. And at 3 months, he has an almost perfect function, not only of the intersectional movement, also the lateral movement. So this I haven't seen with the extensile approaches. They have need more and a longer rehabilitation protocol. What to do if the calcaneal cubital joint is displaced? Then you just prolong your incision from the sinus tarsi, and you aim for the 4th metatarsal base, not for the 5th, for the 4th. And then you right over the center of the cuboid. And then you can see you can reconstruct the cuboid under the same direct vision. You can see that you have did a perfect job. You see the screw in this below the subtalar joint. So joint reconstruction first, and then in this case a little longer plate is slid in again in a Whipple technique. And this is a special animal, the so-called fracture dislocation of the calcaneum, where the whole body of the calcaneus is dislocated upward, hitting directly the distal fibula, sometimes producing a fracture, always producing a peroneal tendon dislocation, and sometimes it extends, sometimes it's a simple 2-part fracture. In this case, also the anterior process, even the cuboid, has some comminution. So we use the same approach, which was described as an epimedullary approach by Hans Swift. It goes along the same lines, starts over the lateral medialis. From there you can fix the fibular fracture, you can fix the peroneal tendons. Then you can see the subtalar joint, which has two big pieces. And then you can go all the way to the front to see the anterior process and even the cuboid. So this is my favorite approach on the lateral side, and it avoids all the vessels and nerves and tendons that are there. The peroneal tendons go down. In this case, they are subluxated or dislocated, so you have to take care. You see they are sling with a rubber band. Then you look at the joint, you reduce it under direct vision. This is very easy because it's typically two parts. The anterior process is a bit more smashed, so this goes second, and then in addition to the screws that cross the joint, a plate is put in for the anterior process, and in the end, the fibula is fixed, and the peroneal tendons go back where they belong, behind the fibula. This is the final result, and this is the patient 2 years later. She just complains that she feels the fibular plate. So she is slated for removing the fibular plate, anything else stays in, and here you can see the lateral movement in the subtalar joint and the movement in the ankle joint, and the approach has nicely healed. So these are, again, the factors that we can change, and as surgeons, we have to restore the outer shape of the calcaneus, because if it's not there, the patient has nothing to walk on. And we have to reduce the joint. If the joint is not reduced, if there's a step off in the joint, the subtalar joint is a non-forgiving joint. It is curved, it is subject to shearing forces. So if the subtalar joint is not reconstructed perfectly, the arthrosis is just around the corner. This again has to do with experience. And it's also the manipulation of the soft tissues, which is very important because it's just skin and bone over the lateral side of the calcaneus. And of course, you have to adapt your treatment. So this is, on the right side is the worst of both worlds. A large approach, a large plate, but no anatomic reduction. So then, this is of course worse than non-operative treatment. So, to sum up, there is no treatment, because it's a big family of fractures, that is amenable for all patients, and this is the same for Pilon, ankle, and calcaneal fractures. The soft tissues around the foot and ankle are as important as the bony injuries, and you have to plan. Do a CT scan, be very generous, even in so-called simple ankle fractures. Sometimes after having a CT scan, they're not so simple anymore. And choose your approaches wisely, minimal approaches if possible, anatomic reduction and post-op control. And if you see there's a step off or some malalignment or some malplaced material in the post-op scan, go to the patient. None of the patients will be mad at you if you say we detected some mistake and we're going to correct it right away to avoid problems. Merci pour votre attention.
Thank you very much. Impressive.